My name's Sam Klempner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, Massachusetts. Yeah, the frequency of imaging in gastric and esophageal patients is actually something that I think is understudied and underappreciated with regards to the disease. So many of our clinical practice is often, guided by experience, and with many tumor types, it's quite standard to consider imaging every 12 weeks as a very acceptable schedule and pattern. And with regards to our patients in the gastric and esophageal world, I don't think that's unreasonable, but I would also recognize that this is a disease that tends to have an aggressive biology. And if you look at many of the first line studies, as well as later line studies, you'll see imaging between 8 and 12 weeks as sort of the most common benchmark standards. Some studies look as early as every 6 weeks. And I think that's just recognition that sometimes the disease biology is moving quite quickly, and we need to understand whether we're having a disease, an anti-tumor effect of our therapies. Personally, in patients who are newly starting on a given regimen, I think that's really when we focus on a little bit shorter interval imaging. We recognize that perhaps a scan within 6 weeks may not tell you the optimal benefit of a given therapy. You may not have reached enough time to see the full effect. However, you may have seen enough time to see whether or not the drug is definitely not working. So if you see significant increase on a 6 or an 8-week interval, it's very unlikely that a 12-week interval is subsequently going to show significant response. So we use it primarily when we're starting patients on first line or second line therapy. We strongly consider, and almost universally do, an early imaging time point, 6 to 8 weeks most commonly, primarily because we want to understand, are we at least heading in the right direction or stabilizing the disease? I recognize that there is not a lot of prospective evidence comparing imaging schedules with regards to outcomes. And this is certainly an area that someone could undertake as research, particularly from a cost effectiveness standpoint. And I do expect that the further integration of additional measures, such as circulating tumor DNA and tumor markers, may actually give us some earlier disease response assessments as they become increasingly validated. So, for example, there's been some studies that baseline circulating tumor DNA followed by a 4 to 6 week time point with a certain decrease in allele fraction or total amount of ctDNA may be quite predictive of going on to receive response. So in the future, you could envision a situation where if you have a certain ctDNA response, you could even postpone imaging if you're quite confident that you're already going in the right direction. Certainly, I do not think we have adequate data at this point for that to be adopted in general practice, but it's definitely something that we're thinking about.